talk about peds, there's a couple like, I'm gonna just kind of highlight the points of things that I want you guys to know, and we're gonna flow through it, kind of just through our basic flow chart. So we're not getting into targeted stuff, but we'll kind of highlight those as we go. So first things first, scene assessment. What's different for a scene assessment when we have a sick kid?
Usually everybody's a lot more high stress kind of.
Sure, yeah, everyone's really high stressed.
And maybe more people around.
Potentially. Pediatric assessment triangle, is that ringing any bells?
Yeah.
Yes.
Okay, what's the pediatric assessment triangle?
Appearance, work
Okay.
of breathing and circulation.
What does appearance mean?
Like, are they, like, can you console them? Like,
Yeah, so is this kid crying? Is this kid awake? What are they doing? Are they appropriately crying? So if there's a nurse holding the kid and they're trying to get an IV in him and this kid's not crying, not good. He should be crying. Should upset the kid. What's work of breathing?
Is there like
Nasal
can you hear like
flaring.
secretions?
Yep, secretions, nasal flaring. Yep.
Sounds.
Retractions, good. Breath sounds, all great things. Kids like to do belly breathing. So seesaw, you'll see the belly go. Lovely. And what's circulation?
Is there skin appearance, so like mold or like blue?
Fantastic. So this is done part of your scene assessment. So at the door, you're doing the pediatric assessment triangle. So in lab, when you walk in and I tell you your patient's a kid, you should do the pediatric assessment triangle before you check for a pulse. Make sense?
When you first.
Yep. And the reason we do this is, are they getting oxygen? Yes or no? So that's the purpose of the pediatric assessment triangle. Are we giving them oxygen? So if we walk in and see a kid who's pale, partner, grab a tank. I'll tell you how much oxygen you're gonna get in a second. We walk in and the kid is lethargic, lying flat in mom's arms. Partner, get the tank. We're gonna get some oxygen out in a second. Kid looks like they have work of breathing, retractions, all that good stuff. Partner, get the tank for me. Make sense?
What is their appearance again?
Kind of like LOC. Are they awake? Are they interacting with their environment appropriately, or do they look really tired? So, pediatric assessment triangle is oxygen, yes or no. Then we move to our primary assessment. Anything different about the primary assessment in kids?
Would it be like LOC and ABC?
LOC is about the same. GCS is a different scale when we get to young kids. They can't answer questions, which makes it tricky. Circulation should be the same, though we'll get into vitals in a couple minutes. Their airway. Kids' airways are a little bit different. So compared to an adult airway, their tongue is relatively bigger than the rest of their airway. So their mouth is small, but their tongue is big compared to the rest of their airway. It means that you don't have a lot of room in there. So if you have like a foreign body you're trying to pull out, or you're trying to put an eye gel or an OPA in, you might have some resistance. It means when their tongue falls back, it can get really bad. So you have to make sure you do good jaw thrusts, good head tilts, all those good pieces. Positioning a kid's airway, make sure that you put some padding underneath the shoulders. Kids have a really big occiput. Back of their head's really big, and it tends to put their pockets. Kids' airways. So, you're gonna be my prop? Yeah. So kids have a smaller mouth compared to adults. Like physically it's smaller, which means you have less room for OPA stuff. Their tongues are also bigger compared to the size of their mouth, which means again, you'll have a hard time holding their airway open. Kids also have a nice big back of the head, the occiput, which means they tend to like kink their own airway when you lay them flat. So you have to put padding back here. So if we do this, whoop, you gotta put some padding there, otherwise his head kind of pops up. Hi. Kids' airways are also really skinny. So whereas an adult's airway, an adult's airway is straight. Little kids' airways are going to be skinny. So what that means is that you're less likely to have a foreign body obstruction in a kid, because once you tip them over, it'll fall out. Make sense? Beauty. So physiology or anatomy is a little bit different. Beauty. All right. So now we've moved to the primary assessment.
Matthew, you took them forward and then it's more likely to come out. That's why you do that.
Correct. Are you going to stand next to Dad? We're on candid camera.
Out of the breastfeeding, so that's a
Okay, so now we're into our objective assessment, so head to toe. Some kids get kind of fussy when we do our physical assessments, so you might have to go feet to head. Don't need that. It's not a rule. I wouldn't say this is like always do kids feet to head, but it's something you can think about, right? So if we got a little kid who's bundled right up, really sooky, maybe start at the feet and then work your way up. Physiologically wise, kids are pretty the same. Though one thing that is different in our objective assessment is kids' vital signs. How is a kid's heart rate different than an adult's heart rate? Excellent. So heart rate is going to be up.
Blood pressure's down.
Blood pressure's down.
Respirates up.
Respiratory heart rate's up. Good. Cool. And then it normalizes, in quotes, as we get older.
Is temperature the same or is it a little
But
bit
the same.
It is.
Kids are prone to get fevers though.
Yeah.
That's why you think they would have higher. Okay. So rather than you guys memorize vitals for kids, understand these trends and then just reference them, look them up. Does that make sense? So I don't expect you guys to memorize 3-month-old vitals and then 4-month-old vitals and 6 months, because that's crazy. Cool, so just reference them, but understand these trends. That a high heart rate is probably normal for a kid. And we'd have to look up a reference to see what is normal. Cool? All right. So that's our objective assessment. Subjective, so this starts getting tricky. Most kids can't talk. So can't really, some talk too much, yeah. Hard to ask kids, how are you feeling? What's going on? And even if the kids can talk, it's hard for them when they're distressed to be specific. So you have belly pain right here. Kids probably just gonna say my belly hurts. And really hard to hyper-focus and get specific. Also, family might not know what's going on. They might not know history. Maybe one parent knows history. I don't know if I know what size shoes Sophia wears. Mom definitely knows. Oh, I do know Sophia likes Timbits. Thank you, sweetness. You gonna give them around? You gonna hand them in? Yeah. I'll hold your little box. Thank you. This is on video too. This is great. Okay. So getting your history from family can be tricky, and we also have to think about neglect.
Thank you very much.
If they don't know the answers, should they know the answers, and are we worried about this kid being safe? Last one is our differentials, or I'm sorry, second to last, differentials. This particularly ties in when we get to things like H's and T's. So kids often haven't been smoking long enough to have a heart attack. If you think about all your risk factors for diseases, a lot of, you don't smoke. A lot of them are chronic problems. Yeah, you don't smoke, right? So a lot of your diseases are chronic, so they don't really apply to kids. You think about like smoking or poor diet, sugar, diabetes, the condition of like type 2 diabetes or ACS. They're not really relevant differentials for a kid. So your differential probably wouldn't be that a child's having a heart attack, right? On the plus side, kids love oxygen. That's why we give them oxygen so early. So usually when a kid gets sick, it's related to a lack of oxygen or lack of perfusion. So they get a fever, they get hypoxic, they get the flu, they get hypoxic, they get sick, they get hypotensive from a bleed, they get lack of oxygen, they get sick. This little fella got sick, he got RSV, and it was all from a lack of oxygen that made him so sick. Again, highlights the importance of O2. One last thing I gotta draw. Kids also, actually two things. Kids also, adults when they get sick, they like to do this, just sicker, 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 sicker. Don't pull my mustache. When kids get sick, they go, hey, everything's okay, and bottom out. And if you think about it, it kind of goes like the oxyhemoglobin curve. So like 97, 98, 99, or sorry, 99, 98, 97, all the way to 90, and then 89, and you start to tank, right? Same thing with kids. They tolerate it well until their sats get really low, and then they get really sick. Cool, now we're into treating kids. Obviously, oxygen. Treat them with oxygen as appropriate. So you asked the question earlier, when would you give them high or low flow? You'd figure that out here, whatever's appropriate for their sats and their ventilation rate. Treating kids, everything's weight-based. Yes, I know. Everything's weight-based. Yeah, you take them for a second. Also very warm. So, whereas an adult we give 25 to 50 Gravol, now we're giving 1 milligram per kilogram. So So you need to figure out kids' weight. You can do that through a Broslow tape or the parents or Pedistat app, whatever.
Your best bet.
Broslow tapes
I
work
wouldn't
great.
even tell you his weight right now.
So all of our drugs, you have to be careful that there's a weight-based version, right? There's a weight-based formula. So just be careful of that one. Fluid for kids, it's still 10 to 20 mils per kilogram, which is what we were doing for adults. But now we have to think about how much that is. So if Theo weighs 20 pounds, so that's 40 kilograms, that means he's getting 400 to 800 mils. That's a fluid bolus. That's the equivalent of me getting a liter to 2 liters. So you probably wouldn't hang a liter bag for Theo, otherwise you're gonna fluid overload him. Does that make sense? Hey, sweetness. 10 to 20, so that would be like a fluid bolus for a trauma bolus, right? Maintenance fluid for kids, so like for us, we might give, hey, where's your Timbits? There you go. Maintenance infusion, you might give, like for an adult, 30 mils an hour, right? You just set your drip rate, and that would be like TKVO kind of deal. Don't do that for kids. We do a weight-based formula for that. So it's 4, 2, 1. 4 milligrams per kilogram for the first 10 kilograms. 2 milligrams per kilogram for the next 10 kilograms. And 1 milligram per kilogram for everyone after. You're making a face, so.
Just repeat.
Yeah.
Sorry, what?
Okay, 4 milligrams per kilogram for the first 10 kilograms. Then 2 milligrams per kilogram for the next 10. Then 1 for everyone after.
As in, like, do the calculation for that 4, run that. After that, do this.
Nope, it'll all stack up.
Once you do 10,
Yeah, once you do 10, fix your math and do it now. 2,
first 10 milliliters.
Let me do an example, I can show you.
please,
Okay.
because my brain
So
hurts.
we got a kid who's, let's say, 40 kilograms,
Okay.
right? So for the first 10 kilograms of that 40, he's gonna get 4 milligrams per kilogram. So that's gonna be 40 mils, sorry, not milligrams, 40 milliliters per kilogram. Right?
This is for fluids.
Yes.
I'm confused.
Hold on, sweetness. So we just used the first 10. Now we've got 30 left. For the next 10,
10
we're gonna get
what?
2 mils.
Yeah, 10 what, sorry.
10 milliliters.
10 milliliters per kilogram.
Okay.
Per kilogram.
Yep. So for the next 10 kilograms, he's gonna get 2 mils. So that's gonna be another 20 mils. Right? That means we've got 20 left over.
So I was gonna get.
For that last 20, he's gonna get 1 mil per kilogram. For the last 20 kilograms, he's gonna get 1 milliliter per kilogram. So that's another 20. So that means this kid is gonna get 40 plus 20 plus 20 means 80 mils per hour. And that's like an infusion, a maintenance infusion form.
So that's an hour thing.
Yep, per hour. So you set your drip rate to 80 mils per hour. Does that make sense?
Oh.
Cool. So the take home for treating kids is slow. It's a lot slower to treat kids because we have to check references, we have to do math, we have to double check our math. So it's not like adults where we could just, here's the Gravol, push it in. Now we gotta figure out how much we're giving them. You have to make the sound of that too, right? Cool?